Thank you, Sneha. Thank you. And thank you, everybody, for coming. And it's a perfect positioning to go into really what we're presenting as what is the standard of care? Because this is a question that we get. It's a question that many people wonder, and probably that many of you get, right? So what is the standard? And is it defined? So we're saying this is the standard of care for New Mexico. And of course, as Julie said, everybody who is here was invited on purpose because you are awesome. Really? Yeah, because you're doing this work, because you're interested in doing what's right and serving really the underserved, as we just heard, no matter what somebody's demographics are that fit into this category. And so what we want is we want to be sure that we are all on the same page, right? What is the standard of care? So this is the New Mexico Opioid Hub standard of care. And it begins just with a talk about what is evidence-based practice, because evidence-based practice is really not just that there's evidence, right? There's not evidence for everything out there, but when there is evidence and then we blend it with clinical judgment, makes sense. But I think it's important too when we talk about standards, what should we do and what should we not do? What evidence-based practice is not is any of our personal preferences about a given medication. Right? That's not evidence, that's personal. It's really important we all have our personal preferences when we're making our own healthcare decisions about our own treatment. I would say it's not appropriate for us to project our preferences onto our patients. Right? And so to do this, to really be evidence-based, we all need to look inside a little bit and confront our own stigma. Right? How do you feel about methadone? Because if you dissuade people in general from methadone treatment, you are promoting your personal agenda and not practicing evidence-based treatment. That's not an evidence-based approach. The whole point of evidence in the scientific method is to get beyond our personal biases. Right? It's important. All right. So the best chances for people to achieve sustained remission and recovery is this. This is evidence-based treatment with medication-assisted therapy. As Snehal said, is it okay if I call you Snehal, Dr. Bhatt? There are 3 medications that work for opioid use disorder. That's it. Buprenorphine, whether it's sublingual or an implant or an injection in this new form that lasts a month, as maintenance treatment, methadone maintenance treatment, and naltrexone, or we could even call it naltrexone maintenance treatment. That's it. So if we offer somebody with an opioid use disorder treatment that does not involve one of these medications, we're being negligent. We're not practicing evidence-based care. This is it. And unfortunately, there are lots of disease processes where we can be a little innovative and go beyond the evidence and even take non-medication treatment approaches, but with opioid use disorder, that results in death, unfortunately. The stakes are simply too high. And again, it's really all 3 of these should be offered as equally effective. And even if, let's say you don't have a methadone clinic, let's say you don't dispense, you're not an opioid treatment program, but you're treating and addressing opioid use disorder, it would then be inappropriate for you to dissuade people in general from seeking out methadone. Or for you to promote this idea that methadone is not a good medication, or that buprenorphine is not a good medication, or that naltrexone is not a good medication. We can say the evidence is they're equally good. Some are a better fit for any individual patient, but patients should make that decision, not us. We should not make that decision for our patients. Also, as Snehal said, it's really not okay for any of us to promote the idea that any form of medication-assisted treatment like opioid replacement is replacing one addiction with another. How devastating of a message is that to somebody who is doing well, right? Who talks to their patients about, are you able to like not keep this as a secret in your NA group? Right? We talk to people about if your sponsor tries to get you off the medicine, maybe you need a new sponsor. Let's not be in that same pool as healthcare providers, right? These are all three good. They all three work. And these all constitute an abstinence-based approach. Abstinence means I'm not using the drug that messed up my life anymore. So again, I would say it's not appropriate for us to say Suboxone treatment is not abstinence-based treatment. Or for any of us to say, we're an abstinence-based program, we offer naltrexone only, and not opioid replacement. It just doesn't work anymore, and it's devastating to patients. We're making decisions for them and not practicing evidence-based treatment. There are, of course, also non-medication treatments, but they all need to go along with the medicines, right? In the study where non-medication treatment is combined with one of these three medications and compared to people who only get a non-pharmacotherapy for opioid use disorder, people don't do well. Same thing in the study where everybody gets, for example, buprenorphine treatment, and half of them got non-pharmacological treatment as well, counseling, and the other half just got Suboxone. There was no difference in the big group in the treatment outcomes. Now, that doesn't mean that therapy doesn't have a role. It absolutely has a role. It just means that maybe not everybody needs it. And there are great therapy treatments out there, right? Cognitive behavioral therapy for relapse prevention. It's beautiful. If you ask the Cochrane Review database, does it work? It says there's insufficient evidence. But boy, my patients sure say that it was helpful to practice refusal skills, and it was helpful to stop hanging out with people who are using heroin. So we know it works. Community reinforcement approach, which is just a brilliant and a beautiful evidence-based way of using motivational interviewing. Motivational enhancement therapy to get people into other treatments. 12-step or mutual help groups, right? It works if you work it. And it certainly helps people get into those and access mutual help groups if we talk to them about them. That's 12-step facilitation therapy. Seeking safety is awesome, right? Especially for folks who have this comorbid PTSD and a substance use disorder. And then as I think we all appreciate, and as the state is really trying to increase, getting Narcan into every household possible. I would really encourage all of you to go to your pharmacy and buy Narcan and carry it with you. Let's model that. It's in my jacket pocket in my car. Carry it with me every day. Bravo. Now, we talked about this already. So how long should treatment go? It should go as long as possible. None of the studies have said, here's a Goldilocks duration of treatment, and then people can be stopped after that. But all these pooled studies do say that 90% of the people who come off of one of those three medicines do very poorly. They relapse, and too many of them die. So if we're feeling philosophically we should get people off of medicine, again, I urge you to answer the question, why does that feel like it should be done? And just 'cause isn't really evidence, right? Again, we want to not confuse our philosophies, our personal philosophies, for science. So we want to encourage people to stay on these medications as long as possible. And if one of those three medications isn't working for them, we want to encourage them to get on one of the others, right? Awesome. I think it's also really important, no matter what setting we're in, that if we're talking to somebody about one substance use disorder, we should talk to them about other substance use disorders, right? So I get a little heartbroken when I call a clinic and they say, we just treat opioid use disorder. We don't really address alcohol, or we don't really want to address their benzodiazepine use. Right? We need to take a holistic approach. Same thing for other psychiatric diagnoses. Now, we don't all have to be psychiatrists, but the guidelines are out there, and the treatment's pretty straightforward to treat depression and treat anxiety, treat PTSD, right? And certainly address suicidal ideation. We talk almost exclusively about accidental lethal overdose, and I think it's really important to remember that in New Mexico, about 15% of the opioid overdoses are intentional. They're suicide attempts. And we can't forget those. Now, how are we going to work people up? So we can't always do all these tests in our setting. But as a standard of care, I think it's really important. I think our patients deserve that we look beyond just the one thing that we're identifying as their substance use disorder. Do a complete blood count and see if they have an infection, and do we actually need to kind of look at something else and get them to a hospital. looking at their hepatic function and their renal function. Assess for pregnancy, because that can affect certainly the trajectory of treatment and our approach. Screening for hepatitis C, which is in our state we've done a really good job of, need to continue to do. HIV, other sexually transmitted infections, and really asking people about their heart, right? So, Snehal is a psychiatrist, and he's talking about treating Hep C, right? I'm a psychiatrist, and I get out my stethoscope, and I listen to people's hearts, and I ask them about this because we need to be holistic in our approach. There's a whole person in front of us, not just a psyche, right? We need to look at their skin. If they shoot up, we need to ask about things like sleep-disordered breathing and evaluate for COPD, because these are just all risks, right? I think we can all be more holistic. I know that lots of you are holistic in your approaches, but I think we just all need to challenge each other to even be more so. And then psychosocial factors, right? Sometimes legislators grab me at a talk and they say, so what can we do to treat the opioid use disorder or the opioid epidemic? And I say, give people jobs. And it's not really what they're expecting. They're expecting me to give them an answer about medicines, right? But if you have insecure housing, if you have food insecurity, then that might be a bigger priority, right, than filling your prescription. And if you can't get a ride to the clinic or your phone keeps getting cut off, then it might be hard to stay in and participate in treatment. So I think it's really important that we explore these things. If we can link people to primary care, and those of you who are doing primary care and treating substance use disorders, bless you, you are awesome, because you are more holistic than anybody else. You're treating that whole person and their whole system. And the more we can actually interact with people's social support network as well, the better. I love going to faith-based organizations and other organizations around the state and just raising their awareness about this and helping them understand, here's some signs you can look for in your congregants, and here's a compassionate, non-judgmental approach. That helps them help their congregants. And same thing with the criminal justice system. Some of us were talking about this earlier. If you know a judge, if you know somebody in the parole or probation system, please offer to have a talk with them about treating substance use disorders in an evidence-based way. When there are some drug courts out there that dissuade people from getting into treatment with medications that we know are evidence-based. It's almost like they want people to come back to jail, which I don't think they want. I think what they need is some education, because there's a lot of stigma out there. I've had great experiences talking to probation and parole, spending an hour with them, turn things around totally. Now they're encouraging people to get into treatment. It's beautiful and awesome. That's a community-based approach. That is holistic. And then a couple more questions that Snehal really started to touch on is in terms of the standard of care. So what do we do? Somebody is on one of these medications, and we're doing urine drug screens, and they've got opiates in there, right? Maybe they were doing well, and they relapse. What is the one response we should do? We should reach out and see how else we can help them. What it is unethical to do is to kick them out of treatment. That is malpractice. And it's losing the most important thing we have, which is our relationship with the patient, right? It's as if somebody has diabetes and it's pretty well controlled, and then it's their birthday. And they eat the birthday cake, and they come in and their blood glucose is out of control. We say, no more metformin. You are banned. Go figure it out, right? We laugh because it's like, oh, that's so unreasonable. But it's really no different with this. It's really no different. We need to not judge folks. We need to wrap our arms around them metaphorically and really help them, right? Increase the structure of treatment. Well, what if they come and we're treating them for opioid use disorder with any of these medicines, even a controlled substance like buprenorphine, and now they've got cocaine in their urine, or they've got cannabis in their urine, or they've got methamphetamines in their urine. Naltrexone, we can expect to treat alcohol and opioid use disorder. Methadone and buprenorphine, they treat opioid use disorder, and that's it. It's funny because in our psychology, we tend to clump all the substance use disorders together, but these are all separate diagnoses, right? So we should not expect necessarily that if we're treating somebody's opioid use disorder, that their methamphetamine use is going to go away. Sometimes that happens, and it's awesome. But I have patients who came to me using methamphetamines and heroin and stabilized them on buprenorphine, and now for years they have not used any more heroin, and they continue to use meth every day. And we continue to talk about their meth use. I wish I had a medicine for it. We continue to talk about it, and it never jeopardizes their Suboxone prescription, because the two are in a way unrelated. Now what's different? Different are things that make buprenorphine or methadone dangerous: benzodiazepines and alcohol. And we do need to encourage people to reduce those. Though the FDA is pretty clear, even if they're using benzodiazepines, that's not a reason to not start methadone or buprenorphine. And their letter continues, we need to help them get off of it, right? We don't just tolerate it. We need to help them get off of it. So I think it's important. We should never kick somebody out of treatment for something that has nothing to do with the treatment that we're doing, right? We just need to help them. So thanks, and we are going to go now, right, to Dr. Shi, who is a rock.